my
Yes, yes. Sure,
so
sure, doctor.
I'll be back again. Thank you.
Yes.
We are live now, doctor.
Yeah, thank you. So, good evening, everyone, and thank you all for joining for our late night Retina sessions. Today's session is kind of very special since this is something new which we are trying, and it is named as Masterclass in Diabetic Vitrectomy. And here, let's deep dive into something more interesting and more challenging cases we'll discuss along with our expert, Dr. Salam. So before that, let me introduce to our host, Dr. Bhavik Manchal. Dr. Bhavik is an ex-consultant and head of LVPI Vizag and presently working as a faculty at ESGI hospitals in Ahmedabad. So over to you, Dr. Bhavik.
Yes. Thank you so much, Dr. Avnish. And first of all, a big welcome. Yes, that had to intervene. Yes, a big welcome to all our listeners or viewers. We are back with a bang. We started this third season of Late Night Retina with three sessions on diabetic retinopathy, going into the details of diabetic macular edema, how to tackle with the different kinds of macular edema and the biomarkers. You can catch up all the previous episodes on our YouTube channel. So today, this is something special. We have started with the first lecture on the Retina Masterclass of Late Night Retina. So, continuing with the same theme of diabetic retinopathy, we have a very special guest today, uh, who is a renowned figure in the field of diabetic retinopathy, Dr. Ahmed Salam. Please welcome Dr. Ahmed Salam. He's joining us in a moment. He's figuring out some video interception. So Dr. Ahmed Salam is joining us live from the US, and we appreciate that today being his OT day in between in the morning time, he is joining with us. So what we have in place today, if you look at the theme today, I hope you all can see my slides.
Yes, Bhavik, we can see.
Yes. Yes, so Dr. Salam has joined us. Wonderful. So, yes, can you hear me? Can you hear us, Dr. Salam?
Yes, I can. I'm just
We can see a still picture in your video. Yes, we can see you now. Though
Oh,
it's
you can see me? Okay, I cannot see
horizontally.
myself.
Yes, yes, no problem. But yeah.
Okay, anyway, I'm
Yes.
happy you can
So
see me.
once again, we welcome you, Dr. Salam, on behalf of the entire Young Ophthalmology Society of India, and sparing with us your precious time on your OT day. Thank you so much. As I was mentioning, Dr. Salam is a world-renowned figure in the field of diabetic retinopathy, and today we have a privilege to hear him give his talks on basics in diabetic retinopathy and advanced surgical aspects of diabetic vitrectomy. So the flow here is this will be a video-based discussion where we'll be showcasing certain videos, certain steps in diabetic vitrectomy, followed by certain questions, which will be answered by Dr. Salam and few of our panelists as well. And with this, we understand and we presume that the knowledge of the listeners will be further enhanced, and they will have a lot of practical aspects in terms of understanding how to manage cases of complex diabetic retinopathies or detachments. So, in brief, though this is a very just Dr. Salam's career can't be done in one slide. He is an associate professor at the Harvey and Bernice Jones Eye Institute at the University of Arkansas. He also director of the uveitis services, specializes in the management of ocular inflammation with emphasis on the use of most advanced systemic and intraocular medications. He is also a retina specialist par excellence with expertise both in surgical and medical retina. He received advanced training in Moorfields Eye Hospital as well as two further fellowships in VR surgery in the UK. He is an educational speaker, trainer, researcher, has published over 70 peer-reviewed manuscripts and multiple book chapters, and presents regularly at national and international meetings. So it's an honor for all of us that you have joined us, Dr. Salam. We'll go ahead with the first case to begin with. So this is the short case, and after the case, we'll have some questions, and then we'll go over to your presentation, Dr. Salam. Yes, so this video was by Dr. Abhishek Upadhyay, who is currently a consultant IQ Vision Hospital in New Delhi, and he is also an alumni of Eluprasad Eye Institute. So we go ahead with the questions. I'm just going to read out the questions. Dr. Salam, if you want to answer the questions now, or for this case, or after your talk, I leave it to you. So the first question pertaining to the core vitrectomy and membrane removal. When we look at this video, the questions which came to us when we had a panel discussion for discussing the questions, we wanted to understand what are your tips for safely handling a densely fibrotic posterior hyaloid, like what we had in this case, without causing arterial tears. Right? Like what? Yeah. And how to ensure complete removal of the hyaloid in eyes with severe vitroschisis? A densely fibrotic posterior hyaloid, like what we had in this case, without causing arterial. Yes. Can you hear me? Yeah. And how
Yeah.
to ensure complete removal of the hyaloid in eyes with severe vitroschisis?
Yeah, sorry, I think there is a mix-up on my side from because of the streaming and I cannot see the videos.
Like what we had in this case.
Yeah.
Without causing arterial. Okay. Can you hear me? Yeah. And how
Yeah.
to ensure complete removal of the hyaloid in eyes with is the YouTube link
Sorry, I think
playing
there
as
is
well?
a mix-up on my side from because of the streaming and I cannot see the videos.
Like what we had in this case. Without causing arterial. Okay. Can you hear me? Yeah. Is the YouTube link playing as well?
Yes, doctor.
No, Manjula ji, I think this is the echo from
Sorry,
Dr.
is the question for me or sorry? Yeah. Okay.
No,
yeah.
so
ahead.
could you see the video which was played?
So I cannot see things on the Zoom, but I can see them on the live stream. So
Okay, no problem. So
that's all right.
yeah.
Yeah.
So we'll go ahead with your presentation now, and based on the presentation, we can answer those questions. They're very simple, basic questions. From the presentation, we can answer the questions. So
Yeah, sure.
you
Okay,
want
let
to
me
share your
just try
presentation
to
now?
work. Yes, I'll try to
Yeah.
work on my screen. I can see it inverted there. Not sure what's happening. Okay, yes, all right. I'm sorry. It's I see my screen inverted, but I'm not sure why it's anyway. Right. Okay. Can
Yes,
can
we
you see? Okay,
we
is
can
it
see your
like not
slides.
inverted? Is it okay?
Yeah, it is perfect. Yes, you can just
It's
go to the
okay.
slideshow
Right.
mode. Yeah.
Fantastic. Let me just get out of that. All right, can you see it now? Is
Yes.
okay? Okay, all right, because I cannot see it for some reason. Okay, I just want to thank you so much again for the young ophthalmologist, and thank you so much to you for the invitation. I'm really very grateful and delighted to be here. Just want to update my bio. It's good to be young, but I'm a professor now, so a bit old, and for the publication, I have more than 200 publications now. But anyway, uh, it's bad to be old. I think I would love to stay young. But I'll talk about diabetic dissection. I think few points here. One is which I think was shown in the previous video really nicely, is what's the vitreous status in diabetic TRD. The other one is extent of membrane dissection, and I'll talk about ILM peeling and tamponade. One point I want to talk about as well is preoperative assessment, and I want to spend a little bit of time discussing this, but we can discuss this maybe after the first point, which is the vitreous status in diabetic TRD. So something very important, especially for young ophthalmologists, which I think are the main audience here, is that diabetic TRD, even if you have vitreous hemorrhage, most of the patients with proliferative diabetic retinopathy, they have vitreous crisis. And this is so important because if you think about like patient with vitreous hemorrhage from diabetes and epiretinal membrane, and you think, actually, that's an easy case. It's not. The reason is, if you look here at this picture, this is a patient with just the usual epiretinal membrane. So you have the hyaloid, and then you have the epiretinal membrane, and then you have the retina. And usually, in most cases, these patients have separated hyaloid, right? But that's not the point. But it's hyaloid is a layer, epiretinal membrane layer, and then the retina. You don't have this in diabetic. In diabetic, you have this. You have a vitreous which is attached and splitted, and then the epiretinal membrane is part of this splitted vitreous. So you have this fibrovascular proliferation part of the splitted vitreous. So that's something to understand, because then to get these membranes, you have to lift off the vitreous, which is really completely different from just like regular or senile epiretinal membrane. And this is like more of a blown up picture here done by my previous fellow, Dr. Riley Sanders. And you can see here where the red arrow is. This is the epiretinal membrane. It's at the fusion of the two layers of the vitreous chiasmus, which is important because to access this membrane, you have to think about how to access. If you try to go number one, which is the most obvious, you got this raised layer and you think this is the plane, it doesn't go. So to access this layer, you have to go from number two, which is actually lifting off the more peripheral vitreous chiasmus layer of the retina and going this way, or you can go from number three, which is my preference, in-out dissection. And the reason is usually there's no vitreous chiasmus over the macula posterior pole. So that's where it actually becomes easier. And I think that you have to take this in consideration every time you're operating on diabetics, because with diabetic TRD, 95% of patients or more have vitreous chiasmus. And I'll show you here. So here, this is a very old video, but I was trying to get to this membrane. You can see here where I put the green arrows, there's like reflection on the level of the retina, more peripheral to this. And this is actually not the correct plane. So this plane is not going to get me to the membrane. And then you can see here, this is like going the other way. So I went in, out, I reached to this membrane. You can see here when I reach to this membrane. Okay, just to show you briefly, this is the in-out dissection, which I start with a pick or forceps usually over the nerve. A little bit of peeling, get you in the plane. But I want to get you to the main point here. Once you get to that point here, you can see here, once you get to that membrane is connected peripherally with the vitreous. And you'll see it opening it up here. Otherwise, you cannot get to the peripheral vitreous. You can try the other side, like going from the periphery to the center, but usually it does not work very well. And then here, you're in business. So this is all one layer, which I think is fine, even if you cannot dissect that and you just trim around it. But you need to understand that you've left the peripheral hyaloid. It's not like we do surgery, we do vitrectomy, hyaloid separation, peel off the membranes. It doesn't work like this. It's all connected. And I think that's something important in diabetic patients to understand. So this is usually how I, before going to that, I think it might be best to spend a bit of time talking about preoperative preparation, uh, which I'm happy to stop here and then we have a second part of the video. But I think the point is when to operate and what do you do preoperative and what to tell the patients. And I think these are very important points. You operate when the vision is affected or threatened. You have to be cautious when the patient sees well, but the vision is threatened because there's tractional retinal detachment just about to take the fovea. And I think that needs a lot of discussion with the patient. If the eye is very ischemic, and especially if the other eye is good, then you may argue, and the vision is very poor without really like obvious traction problem, and it's obvious that this is ischemic and the disc is pale, these patients may not benefit from surgery. So I think you need to weigh in patients with good vision and patients with bad vision. And then you decide when to operate and always get the patient involved. The status of the other eye is also important. The other thing which is important is what to tell the patient before the surgery. And one thing we found is very, very helpful, which we always tell the patients about the risks. We also tell the patients that 7 out of 10 would have vitreous cavity hemorrhage after the surgery, and that 10% only of these patients will need resurgery. And that's makes a big difference. When we don't tell the patients, they get so frustrated because they're expecting that you do the surgery, they see well, which is, I think, is not the case in diabetic vitrectomies. There's a very high chance of vitreous cavity hemorrhage. Unfortunately, usually it all goes away. And the other thing we also tell them about the small risk of rhegmatogenous detachment, especially if surgery is complex and you have like complex membrane and tractional detachment. And I usually cite that we will have a detachment of the retina, which is serious in about maybe less than 5% of the patients. So this is something for us important to tell. Do I give them anti-VEGF? I give everyone anti-VEGF unless it's like not too much vascularity there, and I inject it about 2 to 3 days before the surgery. Evidence shows the angiofibrotic switch happens around 10 days time. So I think if you give it 2 to 3 days time at the surgery is good. And then if I find them oozing a lot at the end, then I will give another Avastin at the end. That's what I usually do before surgery. General local, I prefer local, but if I think this is a case that would extend more than an hour and a half, I'll put them to sleep as much as I can. Sometimes they're very unhealthy and you cannot put them to sleep. Do I take the lens out? No, I do not take the lens out, but I'm prepared. If a case is going to go long, at least I have some measures because I may need to get the lens out. In my experience, you have about an hour and a half, and the lens after that is going to go cloudy. If you're at the end, then fine. If it goes cloudy, it clears. But if you're not at the end, you may need to take the lens out. But usually I try to keep surgery simple and do not take the lens out. And then I think other points we can discuss is just ILM peel and Tamponade. I think we can discuss these with further videos. But I'm happy to stop here and get questions. And then we keep going with the cases as planned, and then I can have another short talk on the technique.
Yeah. So we will take some questions in between so that we have the cases which were submitted to us for your inputs. So
Okay.
I'll just share the presentation. Yes. So on the previous video, you answered to an extent. Whether you want to add more to these questions about the safely handling of the fibrotic membrane without causing iatrogenic tears. And I think you answered the second question about vitroschisis, that how to approach the membranes from point A, B, and the C, right? Not going how the vitroschisis vitreous differs in such cases compared to the vitreous attachment in the case of senile epiretinal membrane. So you want to add to the first question here?
No, I think exactly what I said. I think it's the mindset. You need to understand this concept of vitroschisis, which is very, very important. I remember when I was a fellow, my boss was really a fantastic surgeon. He used to really like emphasize the importance of getting in the correct plane and then you're in business. And he used to go out in by like scratching the retina peripheral to that like posterior layer of vitroschisis and then it's going in this plane. I tend not to do this. I tend to go in out, which I think is easier way. The only problem is you may have bleeding because you're working on the optic nerve. So I tend to put the pressure up as I'll show you in one of the videos. The other thing is how to ensure. I think just knowing about this phenomena, you can use also Canalog along the line, especially after you started some dissection to see it more.
Okay. I think we have a question uh, in the chat box pertaining to the topic which we're discussing. That can we, this question by Dr. Deepak Bhojwani. Can we leave extramacular and epipapillary membranes after relieving tractions and vitreous surrounding them? Can you leave the
Yeah,
membrane as it is?
yeah, my view really with any surgery is honestly less is more. I think you remove the macula, clean it, nice. I think job is done. Then you try the periphery. If it goes nicely, very good, excellent. If it doesn't go, I would stop. I don't want to have breaks, end up with oil. And I think the patient would do much better leaving peripheral traction and they may not progress. Yes, of course, if you remove everything, you've decreased the risk of post-operative vitreous cavity hemorrhage, late type. You decrease the risk of maybe some possible rhegmatogenous detachment if that progresses. But again, you have to weigh all this in with a very, very high risk that you end up with, especially if it looks like very dodgy, that if you end up with a tear, you'll not be able to dissect around it, and then you end up with oil. I think this is a bad combination in my view. So yes, I think you have to weigh everything in, and it's best to leave things. And there's always tomorrow. I
Yeah.
think I remember, something I think of in two situations. In when you diet, you can think like, actually, I'm not going to eat this today. I'm going to eat it tomorrow because there's
Yeah.
always tomorrow. And the other thing is surgery. I mean, if there's a problem, you can come back. But I think it's good to like now finish now and just do the least required.
Yeah, I think that this is a very important point what you brought in. Thank you so much for your inputs. So I request all the audience, Dr. Deepak, thank you so much. Wonderful question. I request all the participants to ask me the questions on the YouTube chat as well as in the Zoom case here. We'll move ahead with the second case here. So let's have a look at this case. So densely adhered membranes, more of fibrotic component and less vascular. So this video was submitted to Dr. Tanya Jain, who is a consultant from Strauss Charity Eye Hospital, New Delhi. So thank you, Dr. Tanya. So pertaining to the questions that you mentioned that you do prefer using anti-VEGFs in your cases. So the question to it, a follow-up question would be that what is the ideal timing between anti-VEGF injection and surgery to maximize its benefits while minimizing the complications? And how does the use of this preoperative anti-VEGF alter your surgical plan? In terms of membrane dissection, hemostasis, sometimes we see the vascular component goes away and the dissection becomes much easier as well.
Yeah, I mean, I think I think operating within a few days is really very good. There's a beautiful paper by the late Dr. Hazem al-Sabah from Saudi Arabia, published in Ophthalmology, I think was in the early 2000s. A beautiful paper. They look at histology and they found the angiofibrotic switch happening at nearly like day 10. So I think if you operate within a few days, it works well. So like the way it works for us is about 3 days. That's what I would do. And I think it makes surgery much easier, really. It was the anti-VEGF beforehand.
So are there any cases where you would not prefer anti-VEGF and directly go for surgery?
I think cases where they don't have very vascular, we may not, if patient, or we may skip it. The other things if patients cannot come for some reason. Sometimes we face that situation, but otherwise I would always use anti-VEGF. I mean, I don't tend to worry much about crunch syndrome. I think the risk is not very high, and I think we're going to be operating. I see the point as well that patients can be canceled, but again, I think just keep things simple. I think it decreases intraoperative and early onset vitreous cavity hemorrhage, and it does help. So I would always consider it.
Okay. Any preference for anti-VEGF or
What's accessible for us is usually Avastin or some samples of medication. I use anything which is available.
okay. Once again, a request to all the participants to shoot in your questions in the chat box. Yes, so we have a question here. I think we'll be coming to this question about role of belt buckle in combined retinal attachment. We'll be going to this question in some time. Yes, so the question here from Dr. Nasir is that if we relieve the traction, then it is important to remove the fibrovascular membrane which are extramacular. That I think it's a comment. So the comment is, if we relieve the traction, then is it important to remove the fibrovascular membrane? I think we answered this question. Yes. Okay. So Dr. Salam, this is an interesting question here from Dr. Rakesh. In clinically ischemic macula with macular TRD, will you still operate?
I think it's a balance. So it's a balance, the vision and operation and the status of the eye and the status of the other eye and what the patient wants. It's all, I think you have to factor all this in. And the risks that you know, for example, is this looks like an easy one or really looks like very bad one, and it's for example a combined traction rheumatologist, or it's really like a very bad traction one and you may end up in breaks. I think you have to factor all this in and come up with a decision with the patient. So I mean, if it looks very ischemic and the retina looks like terrible and the other eye is good, then I would tell the patient there's really no point operating. While if the other eye is not good, then you may really lean towards operating. So I think you have to balance everything, and you have to explain to the patient it's not like a mechanical thing. It's not a cut and paste. It's not like we've done take this off, then vision is going to suddenly improve. Especially when there's not too much vitreous hemorrhage to account for the decreased vision.
Okay. Yes. True. So maybe a follow-up question on this role of anti-VEGF injections at the end of surgery in diabetic vitrectomy, especially in oil-filled eyes.
Yeah, I think it decreases what we know. It decreases early postoperative vitreous cavity hemorrhage. It does not decrease late postoperative vitreous cavity hemorrhage. And early postoperative vitreous cavity hemorrhage, there are reasons for it, as we know. One of them is like oozing from the vessels we cut, and also the other one is leaching from inferior vitreous hemorrhage that is left. I don't think that it decreases this, but it decreases oozes from the blood vessels.
Okay. So thank you for your questions, guys. Please keep them posted. We'll go to the next case here. So this is an interesting case, an interesting concept. So every question, every video, we are targeting a concept. Like we had one membrane removal. Second was about anti-VEGF. Let us see the third video here. This is by Dr. Sharad Hegde, very good friend, and he's from Prasada Institute in ODP. So this is a subhyaloid hemorrhage which has been aspirated. So we see here that the blood is not stopping. Then we realize it was Okay, so I hope the video was clear to everyone. We'll go with the next set of questions in terms of understanding iatrogenic breaks and retinal tears and management of intraoperative bleeding. So the question here to your Dr. Salam is, how do you manage intraoperative bleeding? You mentioned about oozes happening, but if there is an arterial bleed versus venous bleed.
Yeah, I think it's a good point. I think anti-VEGF beforehand does help. Raising the pressure, especially at the time where you're expecting to have bleeding. And that time is, for me, is when I start to the in-out dissection and I start peeling with the forceps over the nerve or with a pick to lift things up. So I usually put the pressure high to 60. Um, what I've learned as well is if you have bleeding, I try to avoid diathermy as much as possible, especially when the area that I'm gonna burn with the diathermy is like flat on the retina. I think if there's something standing up proud, then I can diathermy them without like much fear. But otherwise I try to avoid weak areas that may cause breaks. I think if it's leaking much and you're still early in the dissection, you have to diathermy them and then deal with the consequences and maybe laser around it and leave air or gas if you need to. If it's on the late side, I would just wait, and because the bleeding is not going to affect me much. And usually bleeding when you're at the end, and even if you leave bleeding, as long as you did not use oil, that bleeding goes in the vitreous cavity and it goes away. So I think raising the anti-VEGF, raising the pressure, diathermy, but you have to be careful because diathermy causes ischemia of the retina, and the retina is already fragile. What else I do? Sometimes you go to air, and that helps really compartmentalize the bleeding and give you a bit of time, and you get more like homeostasis better under air than fluid. I've seen people using to seal, but I've not used it. I think it's probably it works if the bleeding is not too much. You can put some to seal on it and just seal this area. And I've seen people using also what's the name of the medicine? What's the name of the medicine used in orbital surgery and DCR to decrease bleeding? I've seen Barbara using that during vitrectomy. I think she showed a case, but I've never used it. I think it's a good idea, but I've never used it. Don't have experience with it. What's the name of? I remember this medicine, but yeah, that's what I tend to do. Yeah, tranexamic acid, correct.
Yeah.
Yeah, I'm not sure about the toxicity. I'm not sure about the dose, but I mean, I remember a couple of cases where I had to close because of bleeding. I think it may be worse if you got up to that point to use that tranexamic acid, but no experience with it.
Okay, so people also mention, and there are papers on that you can also laser the area which is actually bleeding, and also use your cutter head to just
Yeah,
cut on the vessel to close it under air.
yeah, I agree. I think you can do that as well. One thing I tried which does not work, I mean, it says that you can laser the bleeding, and even when the bleeder is like very, very minimal ooze, I've tried laser it. I don't, it doesn't work in my hands.
Yeah, okay, true. So the next question here is, any role of hypotensive anesthesia to reduce the bleeding?
We've never used that, and I think
Okay.
most of our patients are under local anesthesia, so we tend not to do that.
Okay. So others, I would I would like to bring the next question into frame and give a background. Uh, Especially when people are learning during your fellowship, say the retina is under the cover of the hemorrhage, and you may tend to injure the retina or create a iatrogenic break or retinal touch with the fluid or with the cutter. Like in this case, there were breaks. I'm not sure the breaks were beforehand or it happened at the time of aspirating the fluid. So how do you approach such iatrogenic retinal breaks? And if the breaks are at the posterior pole, what do an ILM peeling around the break as well?
Yeah, I think that's a great point. So you have a break in the posterior pole. So I had only one case where we had, and I'll show it in the presentation, where we had a detachment from a break in the posterior pole. Although actually we peeled the ILM, we happened to peel the ILM around it. So usually I don't do anything for these breaks. I think in diabetics, maybe you can do a very gentle laser if they're not so foveal. I mean, that's in retrospect, but I only had one case, and we had like cases before with several breaks in the posterior pole. And as long as there is no traction on them, I usually leave them and leave gas. But I'll show you this case. The other thing is if you have a more peripheral break, then you need to re-laser or cryo around them. I think the question really, which is something I think I've learned from you guys. I mean, I know that lots of people from India, including Dr. Tyagi, used to seal, and I think it's a good idea because sometimes you have a break and like central or near central, and then you have lots of blood on it, and you cannot laser because the laser makes the uptake of the blood makes the uptake of the laser so unpredictable, and you can burn the retina and you can pop up more tears. And I think that might be a nice indication of to seal there, to just seal this area. I have not actually no, I've used this in one case, but I have not used it more than this. And I think this is a good indication in this situation where posterior, there's lots of blood and you cannot actually laser around it.
Okay. Yeah. Yes. So thank you so much for that, those questions and the answers as well. So we'll go ahead with the next case and just showcase the video. After that, again, we'll go back to a presentation, Dr. Salam. So this is by Dr. Sarang Hansraj, who is also my colleague from L. Prasad Eye Institute. So this is a 53-year-old lady with CFCF vision, combined retinal detachment. So I would like the viewers to look at the dissection here and what happens in the further steps. Interesting questions coming up on this case as well. So look here, what is happening. So biminal dissection has started. And even PFC is injected.
Sorry, I'm seeing the previous. I think there's a bit of a delay in the live transmission. Let me just try. Yeah, okay, I'm on.
Okay. Could you see this video?
Yes,
Of
yes, no, I
the
can see it
peripheral
now.
membrane?
Yeah, I
Yeah.
don't know why on Zoom I cannot see the videos, but I can see them on the live transmission.
Okay. So the questions here, which we need not answer, we'll go to a presentation and we'll come back to those questions. The question here is, what techniques do you recommend for safely addressing strong vitreous adherence, especially in the periphery, to avoid the breaks?
Yeah.
And this is a question which is repeated at least 4 times in the chat box today. That do you recommend placing an encircling band in diabetic vitrectomy in such cases when you anticipate the peripheral vitreous will be strongly adhered? Right. So
Yeah.
I'm going to unshare now and we'll go ahead with your remaining of your presentation.
So, okay, so don't answer these now, right? Answer them later, correct?
Yeah, we can answer after
Yeah.
your presentation. Yes.
Yeah, I think that's great.
Yeah. So I will suggest the audiences can also think about those questions and maybe
Yes.
answer in the chat in the
Yeah,
meanwhile.
I think these are very important questions. I'll go through the rest of my presentation. And please do tell me if I'm running behind. So here, I think in this case it's the
No,
same.
we have
So
lots
I
of
will start. Can you see my presentation or?
Yes, we can see your presentation. The
Okay,
video
I think
is
again here,
playing, yes.
start in-out dissection, and you will see that the pressure here, I put the pressure to 60. When I start peeling on the nerve here, and this is in-out dissection, and then I just go from there really, and then it opens up. And I think the point I want to show is a little bit of peeling around the disc, then you engage the membrane, then you dissect out. And yeah, I think this is the point really. When you get to this membrane, then the peripheral hyaloid opens up. And I think this goes with what we discussed, that's all attached and all one layer. Okay, the second point is, I think, and again, I'm sure all you know, the finesse of the 25 gauge and the 23, especially the 25, is just so fantastic that you can get so close to the membrane. And I think it's how you segment is like depends really on how the membrane is. So initially you want to like try to get the membrane to move a little bit. Once the membrane moves a little bit, you can actually go directly on the membrane facing down, which I think is really was the finesse of the 25 gauge vitrectomy probes. Now you can really get so close and you can target the membrane as much as you can. And that's usually what I tend to do here. So you want to really like get very close, and then once it starts to fly off towards you, it works well. Um, and I think again, the point is this is here a similar case. You usually start by so posterior and then move on to anteriorly. And the problem with this technique is bleeding. So you have to be careful really to get the pressure high as you go. Like here, I put on 60, and then you have your way and it becomes easier. And the nice way about this technique, the in out, is you don't get lost in the vitreous because you got the plane right. And that's usually what I always do. And I think here, this is more like, okay, what do you do with the cutter? And it's just finding this plane, and then with the 25 instruments, it's very nice. You can dissect, you can really like lift up. And then once you have a little bit of mobility, it becomes easier because then here you see like, okay, I'm going underneath to lift up. And then after that, I'll go directly on the membrane, even facing down. And it works. Here facing to the side works, but sometimes even facing down. You have to be careful, of course, when you're dissecting over the macula. And same here. I want to show you one where it's facing down. But yeah, I think it's a mix of techniques. And once starts to become mobile, it's easy. Should you remove everything? I don't think you need to remove everything. I think you can leave a stump there, but I would try to avoid making breaks rather than removing stump there. Leaving a stump there is not going to hurt anyone. Okay. So unimanual versus bimanual, I think when the retina is attached, unimanual is fantastic. When the retina is detached, you will have to have bimanual dissection. I like the 25 and the 27 cutters. I think they're very nice, especially the new cutters because of the bevel, and you can get very near under the retina. Again, I mean, I don't think we need to go through the techniques of delaminations and full back delaminations, but once the cutter starts to become mobile, it becomes easier to, once the membrane becomes mobile, it becomes easier to address. This is something we do, which is a 25-27 hybrid. 27 is very nice because it gets you really under the membranes in tight planes. It's easier to get even than 25, but you'll have to have a standalone 27 because the illumination of 27 is not very good. And I have some standalone cutter that I would use with a 25 illumination, sometimes when it's very, very adherent. I think it's useful, but you know, if there are cost implications, then there's no need to do that, and you can get away with the 25 cutters. I think this is the main important, is the extent of the dissection. And this goes with what was the previous video. So this is a patient, I remember this patient very well. I was just out of fellowship training and I did great job cleaning the macula. Now we have this peripheral membranes, and the question is what to do now. So here, right? So I thought, okay, well, they're not very adherent. I'll go for bimanual. And I think, to be honest, in this era with the new cutters, I would have done it maybe even better with the vitrector. So I ended up with a tear, and you can see here a tear mark, then more dissection and more tears and more dissection and more tears. And this patient did so well with gas. But the question is, why did I do this? I mean, I could have just left it. I could have just trimmed and left it because this patient did well, but I had other patients who did not do well. And then when you have breaks or retinectomy, you end up with oil. And this is the worst combination because you've opened the room for PVR and you already have PDR. And this is like the combination of the two pathology is, in my experience, is very bad. And most of these retinectomies roll and they detach even under oil. So I think this situation is better to be avoided. If you find the periphery very bad, I would just leave it before ending up with breaks. Clear the macula, leave it, and we can always come back. Our ROP style. I mean, if it was ROP, you don't remove everything. You just remove what you can, and that's it. That's very good. So that's my advice. My advice is to avoid going in the periphery if it looks very dodgy. I would just leave it. I mean, of course, if it's simple, take everything off, but it looks dodgy, leave it. Don't get into breaks and just clean the macula, and then the patient will be very happy. Yeah, I think this is very bad combination when you have PVR when you open the door for PVR with multiple brakes and traction on brakes, and then in the context of TRD, I think there's a bad combination. I'll show you. This is, I think, my best case to demonstrate what I was telling you. This is a patient who's actually interestingly is 20/20, but she has detached over the years I followed her that her visual field is like this. It's a tubular visual field. So, and the other eye is lost because of diabetes, and she had silicone oil in this eye and retinectomy, and her retina rolled. And then she came to me. I followed her for years because she was doing good. But then, as you can see, all her retina is detached except the very central part, and she cannot function. So this is an indicator, like here, example of the patient nearly 20/20, but I operated on because she's not functioning. And I knew early on that if I try to go and remove everything, we'll end up with a disaster. So I try to avoid that situation. And this is my thinking. I need to go there, work on the macula, dissect a little bit here, there, and that's it. And that was my plan for this case. So here we go in, same technique. So I had a chandelier from the beginning. I go there, start the dissection of the nerve, right? And then I'm here opening up everything as much as I can. And then here, multiple techniques. So here it's becoming a little bit risky. This is a vertical scissor, but the retina is mobile. So I'll go to bimanual dissection. Then the retina is becoming more mobile because you're removing membranes. And then I came to the point where I thought this is becoming risky now. We're gonna end up with breaks. So at this point, you want to stop, and that's enough. You leave the rest of the traction and the rest of the vitreous. So at this point, we stopped, lasered the areas that we could laser because the retina was like on the flattest side, and then air. And this patient did fantastic. And I have her here for several years, and she did really fantastic. And you can see there's traction left behind in the peripheral part, but the idea is just ROP style surgery, no breaks, and just leave behind. And I think this is much better than you end up with a 360 retinectomy in this patient, oil. You open the room for PVR, the retinectomy rolls, and then you end up with a very bad outcome. So I think, you have to be very careful with dissection, and less is more. And that's where we started, and that's where we ended. ILM peel, I mean, I think it's very attractive to peel the ILM in diabetics, and you have all these technologies and brilliant peel and all these elimination, but it's not without a risk. And the ganglion cell layer is already very small in these patients. So in general, I try to avoid peeling in this patient. And yes, maybe it decreases epiretinal membrane of the macula, but I think they do much better without peeling the ILM. And the ganglion cell layer is very small. So I'll show you a case. This is actually a very interesting case. This is my fellow was operating here, and we did nice dissection. Everything looks really good. And then here, this is the case at the end. So you got intraoperative OCT, and this is how the macula looks like. So maybe question to you, would you peel the ILM? I mean, this is the macula looks like. Yes, there are some folds, but his macula looks really good. So would you peel the ILM or not? What do you think? Peel the ILM or no?
It's very tempting to peel, but I
Yes,
would
right. And that's what I told the fellow, let's peel. And then he told me, you told me not to peel the ILM in diabetic. So I thought, well, there are wrinkles there. I think let's peel it. Okay, so he was right, actually. So here we started to peel. And you look, I mean, he did a great job. And here, nice staining. And then you can see here, there's actually, he did not touch the retina. It's a stretch break, which is going to happen. I'll show you in 1 second. And his retina before, his macula was not detached, but it's so adherent, and the retina is so thin. You can see it here. It's a stretch break. He did not really like make a hole in the retina. It's a stretch. So what do? You peel away from it. You come from the other side. So anyway, we peeled all around it, right? Nicely here. And then we laser the rest. And then we put gas in the eye. And then this patient, we thought that's it, done. There's no traction on it. And then 2 weeks after surgery, he came with this. And you can tell this is actually a rhegmatogenous detachment in this area coming from the break. So then we went back, drained from this break, and then did a little bit of airflow exchange, did a touch of laser, and we used long-acting gas, and he did well. But he could have done better if I left his ILM. So I think less is more. This is something I do now, but to be honest, my advice is even like to leave alone. That I do something called a mini ILM peel, which is I'll show you. So here, like here, the traction seems to be coming from this area there. If you look, traction point is from this area there. So I would just peel an area there away from the fovea, like the fovea is here. So the lines are there, so I'm just interrupting the lines. But and I try to avoid the fovea because of the reason we discussed, and that's it, just a mini ILM peel or a bikini ILM peel, whatever you want to call it. But I think, honestly, my advice, just leave alone. And if they get epiretinal membrane, we come back. But I feel they do much better with just minimal handling of the tissue. And again, I think we already touched on this, the gas versus oil. I'm just very much pro gas. And this is a patient here where this eye on the left side was operated with silicone oil, and you can see a retinectomy, and it all rolled. And this is the eye now here. And you still can do well, and even if you have breaks. So here, this is the patient here, and I just clearing things to get into the plane. And then after that, I work posterior to anterior. And you want to be very, very careful with the peeling. I mean, you can peel over the retina, but be very careful just to lift up. Just really to gently lift up. And I would be very careful. Peeling on the nerve is a bit safer because you're not going to cut the nerve, but you can get bleeding. And this is here what I'm showing you. You can even cut like facing down, which is, I think with the precision of 25 is fine. And sometimes, I think this is something I sometimes persist more with I take a bit of time before going to bimanual. So I think if you're feeling like segmental, like unimanual is not going, maybe go early to bimanual. But I tend to like the segmentation with the cutter. But here bimanual, and again working to clear the posterior pole, and then continuing with the cutter. And I just want to show you something here. Sometimes you doubt yourself so much, which has happened here. So again, here, dissection, all good. This is an area here which I don't think I had a break, but I was re-doubting myself. Is there a break there? Not a break there. So I was with the back flush, and even with the back flush, I opened a break. So if you look here, and that shows you how the retina is very thin in these patients. They have to be careful even with the back flush, because I don't think there was a break there.
Yeah.
But with the back flush, just like buffing the fluid there to clear the blood. Here, I open a break. Then what you want to do, and I think this is a case where it becomes difficult because lasering under air is difficult. And you have to be careful. And this is here, the peripheral part, so there's peripheral traction there, which again, I trimmed as much as I can. And all I want the area around the break clear. But you can leave, and that area here, I left it. It's really an area I will not be able to do it. And I think you have to be careful here. I was trying to clear around it. We get another break as well. So here I was trying to flatten the retina and laser around it. You have to be careful lasering around blood because it can pop the retina. So I was trying to avoid really lasering over the blood. And I think this might be a good indication for a drop of TCL as well. And then laser air and air gas. And this patient did very well. I think her, let me get you her, this is the other eye. I think her presentation is just shifted. But yeah, this patient did so well. That's her eye here. And you can see the segmented membranes. I think it's fine to leave, even if you have a tear in the retina, leaving traction away from the
Dr.
tear.
Salam, we are unable to see your presentation.
Oh, you're
Yeah.
not seeing it? Okay, sorry.
Yeah, just now. Yeah, just a minute ago.
Okay,
30 seconds.
share. Yeah, okay, here you go. Can you see it now?
Yes, we can see it now.
Yeah, so that's her there. And you can see the segmented membranes, you can see the area of traction here. And again, having tears away from membranes, it's fine to leave the membranes as long as they're away from the tears. And again, not an indication of silicone oil. And even tractional retinal detachment is not an indication, traction rheumatologic detachment is not an indication of silicone oil, as long as you relieve the traction around the breaks. And even if you leave traction in another area, that's still fine. That's the patient here with traction rheumatologic detachment, where she had one break and I ended up doing another break during the dissection. And as long as you've cleared around those breaks, then you're fine. Even if there's traction in another area, you can leave the eye under gas filled. And that's here as well, like here. And this patient did so well as well. So I think the reason I don't like oil, I think it's pro-inflammatory. You get worse vision with oil. There are risks, but also it's a worse tamponade. It's hydrophobic. You got this space between the oil and the retina where you get all the cytokines there. In diabetics, you have more cytokines, and that's why you end up with this pre-retinal retro-oil membrane. And if you get, unless you get pre-retinal fibrosis, if you get bleeding under air or gas, it just diffuses in the vitreous. But if you get bleeding under oil, yes, it's nice, it compartmentalizes, you have a view, but this blood doesn't go away. And many times, if you try to go in and remove it, you can actually tear the retina because you get this pre-retinal clot or fibrin. So yeah, I think it's again, my thinking is it best to avoid oil as much as you can, avoid retinal breaks in diabetics and ROP style surgery. This is a nice study. This is a nice study from the UK, which actually gives you a flavor to what happens to UK in diabetic delamination. And I'm sorry. And I think what I want to leave you with is, I'm sorry, the slide is just playing in a weird way. There was in diabetic delamination, 15% only had silicone oil. Risk of retinal tear 30%, risk of rheumatogenic detachment 2.3%, repeat vitrectomy about 15%. I think it's a nice study for benchmarking and gives you an idea about like how things are done in the UK. I tend to, I like Ozurdex, but I mean, it's expensive. I like to shoot it in the eye at the end, especially in patients with macular edema. But you can also leave Kenalog. So we always tell the scrub tech or nurse to have Kenalog diluted that we use for vitreous staining and undiluted for not vitreous staining. And this is an old case, and you can see here I peeled the ILM, which again I would not recommend really. And I think yeah, these are my discussion point that we talked about the vitreous status and the extent of membrane dissection, ILM peel, tamponade choice, and this is the summary of my advice in diabetic patients. I think if you've removed everything, you're a fantastic surgeon, excellent results. But as good, in my view, is some membranes outside the arcades, no retinal tear. I think this is very good as well. Okay, well, you have removed the membrane, but there is a tear or two. You use gas tamponade. I think this is good, right? But I would avoid that situation. You have tears, membranes, unrelieved traction or retinectomy and silicone oil, I think this situation is best to be avoided rather than managed, because these patients, in my experience, they don't do very well. So usually, what's my indication of using oil in diabetic cases is the situation number 4, and I always think I should have avoided that situation. And that's why when I put oil in diabetics, I usually don't take out. These cases are, the numbers are very small, and these are cases which I should have avoided that situation. And it's an I, in a way, I'm writing it off. So I usually don't take the oil out in diabetic patients. And yeah, thank you. So I think in reply to your question, I think I would avoid that situation of having like tears, retinectomy in diabetics in the periphery.
Yes, wonderful. I think this is one of the brilliant masterclass that we had, and this is in true sense a late night retina. We are attending diabetic retina session at 10 o'clock in the night, and with over 60 participants on Zoom actively asking questions. So I'll come back to the question. What we asked, is there any role of encerclage or a belt buckle encerclage in a case of combined retinal detachment or a tractional retinal detachment in a diabetic case?
Yeah, I think it's a great question. I think again, I think if there's traction only and there are no tears, I would not do any cerclage. I think if you have tears there and you cannot relieve traction and they are peripheral, I mean, I think you can try to put a buckle to relax this area. Which again, I think what they do in ROP, if you have ROP and you have a tear in a clean area of ROP surgery, you can actually get away with gas in the eye. And I had that situation before. If you have a tear in an ROP case, you've probably lost the battle, but you could try put a buckle. So I think you can try put a buckle there, but in the absence of a tear, I would not put a buckle.
Yeah. Thank you so much for the inputs. Before we go to the next video, we have two more videos. It's an interesting question by Dr. Vaibhav Sethi, especially when you described your inside-out dissection technique. The question is, how do you gauge your pull on the optic nerve head when you start inside out? How much to pull and when to stop? Because we may have the retina thin in the mid periphery, and especially nasal to the optic nerve head, and we may have breaks there.
Yeah, I think it's a judgment call. So I don't think you get. I think you have to be careful because you want to pull on the disc to get a plane, right? But then also, if you get outside the disc, it pulls on the retina. So you have to be careful because you can still tear the retina next to the disc. So I think you have to be careful. So usually what I do is I put the pressure up to 60. I go there with the forces, pull a little bit just to get things started. I have a look, see what's happening. I usually have the magnified lens, but the magnification not so high, so I can see what's happening up. And you just lift a little bit and then you're in business. But it's a judgment call. And that's why some people don't like this way of doing it because of the risk of bleeding. But I just find it gets you really very nice in the plane and gets everything neatly. You're neat, you're in the plane.
Yes. So I understand, Dr. Salam, you have surgeries
Yeah.
waiting. We
Yeah.
won't be more than 10 minutes time. We'll go ahead with the next video. This is with Dr. Anusha, who is a VR fellow from Shankarai Hospital in Bangalore. So we'll go ahead with this video. Okay. So maybe part of the questions are already answered. Like understanding the plane of dissection is the what is how you started your talk. I would like to move to the second question. When would you switch over the bimanual dissection?
Yeah, I think that's a great question. I think I tend to like unimanual dissection, but I think there are situations where bimanual I think is good. It's when the retina is mobile, I think bimanual is safer. And you could argue, if you feel that the case is complex from the beginning, is to put the chandelier from the very beginning, because it's much easier to put the chandelier with the eye being firm. So you have this like four ports arrangement. I think it's nice to put it from the beginning.
Okay, so maybe follow-up question. You mentioned about how 25-27 gauge is helping you for better surgical outcomes without using advanced instruments. Do you think your bimanual dissection surgeries have reduced with the advent in the cutters?
Yeah, I think so. I think so. I think it's the 25 cutter is very nice. The precision is very nice. If the retina is not very mobile, or actually, I mean, it could be mobile in some part, but as long as it's not all of it, or like the majority of it is mobile, I think you can do fantastic with just the cutter dissection. And 25 is nice. The finesse is very nice because the sphere of influence is small. It's very controllable, and it's just fantastic, really.
Okay, so friends, we'll move on to maybe the last video for the day. We have seventh video as well. We'll see if time permits. This is by Dr. Vani from M. Joshi Eye Institute in Hubli. Okay, so I'll go to the second question first. How do you decide when to segment versus delaminate? I understand you explain a technique of going from inside to the outside, but when you have a segment, when you have a membrane, maybe the audience is, because this is the question repeated in the chat box as well.
Yeah, I think so. That's a good point. Uh, um, Again, I think removing everything is fantastic, right? But it's a balance, right? So I think this case actually is beautiful, and the start is fantastic. This is exactly how I would start the case. I think if you can take everything out and remove everything up to like nothing, that's delamination, and you're going in the plane. I think if you're worried about cutting the retina, leaving some stumps here and there, I think is absolutely fine. So I think it depends how the case goes. I would have done I would have done exactly like this, except when sometimes when you come and there's membrane on the retina, you have to be very careful with peeling. I think you still can be a little bit of a lift there, but I wouldn't do more than a little bit of a lift, and even I would try to avoid that because of avoiding tears. And if you have a tear, I would clear around this area, like done, but then I have be careful with the rest, and I would just leave the rest. I think it's I would have again, it's very easy to say things when you're like commenting on videos in retrospect, right? But in the ideal world, I would stop earlier and before the break, or even with one break retraction on it, that's fine. And then leave the rest and laser and put gas in the eye. I would avoid oil. That's what I would do in this case.
Yes. We'll just go ahead with one more video. I'm just going to show important concepts here because I think this one concept is missing here, which we saw in one of your videos. I'll just play the important step here. Yeah. So if all of you can see this, here the truncation is happening. He's going from outside to in. This video is by Dr. Shishir, who is a consultant at Amit Eye Hospital in Kerala. Yes. So I'll pause the video at some point. So if we see here, he's trying to pull the membrane here, but there are membranes beyond this part as well, called as the secondary membrane. Okay, see, this is the primary membrane being peeled, but there are membranes which are coming off, which are not visible to the eye. So yeah, this is the part which I wanted to showcase in this video. I'll continue the video, it's just another minute. Beautiful dissection. So again, he's peeling, and the membrane is way beyond what is grasping of the membrane. So what you see is the primary membrane. What you not see is actually the secondary membrane. So my question was pertaining to this, Dr. Salam. Maybe this is the last slide as such. How do I identify secondary membranes? And tamponade you already explained. So just your inputs on secondary membranes. Yeah.
I think you're absolutely right. So secondary membrane is again another layer for the vitreous chiasis, another name for the vitreous chiasis. And I think the initial paper by Gregor, I think they called it like auxiliary membrane. I can't remember. They had like a name for it, which I cannot remember now. It's like something like a secondary or auxiliary membrane. And I think, yeah, it's the vitreous chiasis. And you can see it. And I think a way to avoid this is exactly like what's done here. You like start peeling from the periphery and then you can see it, or to start from the posterior pole. So you can start over the nerve or the macula. The nerve is probably easier. And then get into that. Then you're working from the stem out. So you're getting all the membranes out. And again, really beautiful dissection in this case. And I think it highlights the importance. Really, you have to be very careful peeling off the retina, because sometimes you get away with it, but sometimes also you don't get away and you end up with a break. So you have to be very careful dealing like peeling on the retina. So you want to segment, delaminate more than peeling on the retina.
Okay. I know the time is up and you have to go and operate your cases. Maybe just last case, because a lot of comments are on there. When you spoke about you prefer gas. However, in India, we use oil a lot, especially when with the younger surgeons. We have this fear that it's going to bleed. The patient's going to complain that my vision has gone back to zero. So what are your considerations for a post-operative silicone oil usage?
Like my consideration, like,
when would you consider using oil as a primary?
I think I consider in the situation which I showed you, like in the last slide I presented, like 4, where you end up with tears and you cannot relieve traction on the tears, or you end up doing a retinectomy, and I think you have to use oil. And I would think this situation is best to be avoided by like avoiding that dissection in the periphery. You play the macula, the periphery looks horrible. You think we're gonna end up breaks here, I would just leave it. And I would avoid that situation.
Yes,
That's otherwise I don't like using oil. I think in general, I don't like using oil in diabetics particularly.
Yeah, I think we figured that out. Yes. So thank you so much, Dr. Salam, for your valuable time. And I would like to invite Dr. Avnish and Dr. Devakan, who has also joined us, who is the president of the YOSI, for their feedback as well.
So let me start, Dr. Bhavik, and special shout out to you. I think
Dr.
you did
Avnish.
an amazing job here. And we are really short of words for Dr. Salam. I think it is one of the best sessions we could have ever had. And we had a healthy strength of more than 50 odd people, like going strength to strength at 10 p.m. in India. So thank you so much. And this is such a webinar where we would really want to visit the concepts again and again. So thank you, sir. And we are like, really, we would really want you back again very soon. And thank you from us. Thank you so much,
Well,
sir.
thank you so much, and thank you for the kind invitation. I always learn a lot from these sessions and discussion. I'll be operating, but I'll leave the things and follow the discussion. And again, so much appreciative of your kind time.
Thank you. Thank you so
Thank you
much.
so much. Thank you.
Thank you.
Devakant, if you want to add something.
Yes, amazing session. This reminds me of COVID days when we used to have
Yes.
with a lot of viewership. So
Yeah.
thank Dr. Salam for bringing back the COVID days for us. Yeah.
Thank you, Dr. Misra. Thank you so much. And again, I appreciate the invitation. Thank you so much.
Look forward to having you again.
Thank you. Thank you, guys. All right.
Thank you, everyone. I think thank you, the presenters. Thank you, Manjula ji, for the extensive broadcast which we had. And thank you, audience. I think we'll come back to you again with more late night retina sessions. Thank you, everyone. Thank you.
Thank you.
Thank you so much.
And congratulations to the team, Dr. Bhavik, Dr. Avnish, and everybody else, Dr. Sharad, Dr. Shishir. Amazing session. Congratulations, everyone.
Thank you.
Thank you.
Manjula ji, we can close the, we can call it a day. We can stop the session.
Okay, doctor, we'll stop this